Is Kristi Hargrove. I'm a pharmacist in the emergency department at University Hospital, and I am here to talk to you about our favorite drug, ketamine. So as everybody knows, ketamine can be used for multiple indications. Our main mechanism is it's an NMDA antagonist, which is what causes that dissociative anesthetic effect. It has a lot of other mechanisms. I'm not going to talk about all of that. That's the nerdy pharmacy stuff. So what I'm going to talk about is what applies to you out in the field. This is great for a lot of people, but just remember it should be used with caution. You can use it for sedation with RSI and post-intubation sedation, excited delirium, pain control, as a bronchodilator, all sorts of things. Just remember your onset and duration are different based on how you're giving it. So if you're giving it IV, your onset's about 30 seconds. Your duration is 10 minutes, but it can take up to 1 to 2 hours to completely have the patient back to normal. For IM, you're going to be a 3 to 4 minute onset, so just remember that there is that time. This isn't that immediate onset, and it lasts for about 10 to 25 minutes for that true sedation, but again, is up to 3 to 4 hours for full recovery, and that's something that you just want to keep in mind. This is all going to be weight-based dosing. That is the big key with ketamine. So estimating a weight or being able to get a weight on a patient, whether it's asking a family member, is going to be very important for this medication, and all of your doses are going to be weight-based. Dose matters whether you dissociate or not. So your low sub-dissociative doses like you would use for pain, your 0.2, 0.3 per kilo, that is going to be below the dissociative threshold. Each patient has an individual response, and different people are going to dissociate at different points. I may dissociate at 0.7 mg per kilo. Someone else may dissociate at 0.5 mg per kilo. So that's why you really want to avoid, this is all IV. When you're giving it IV, kind of avoid that 0.5 to 1 area where we don't know for sure if a patient's going to dissociate or not. Either give your sub-dissociative or go all the way to 1 or above. Same thing for IM. You want to make sure you're hitting that 4 to 6 per kilo IM. Anything below, you may not fully dissociate, and they can actually start to have more of an excited emergence reaction, and anything above can be over sedation. That leads me into kind of how you're going to administer this drug. So if you're giving it IM, this can be a lot of volume. You may need to put it into 2 different sites. If you're giving it IV, you want to be careful to administer it slowly, especially if you are not planning on intubating the patient. Apnea is a rate-related side effect. So if you push it fast, you can cause apnea, and you may need to either bag the patient or end up having to get the airway. Another caution is over sedation. This is that patient that maybe got too much, or they just don't react well, and then they come in and they're GCS 5 and they end up needing to be intubated. This is not something that you're going to be able to predict. This is where it's just really important to make sure that you're using the appropriate dose for the patient as best as you can. Some other cautions are patients in this, and this can be difficult to figure out in the field, those excited delirium patients that may be on meth or some sort of illicit substance. Ketamine is actually not your best option. Ketamine can, like I mentioned earlier, there's a lot of different mechanisms, one of which is it is actually a negative inotrope. Ketamine initially causes a lot of release of catecholamines. This is what causes your increase in blood pressure and increase in heart rate when you administer it. However, a patient that is catecholamine deplete, whether it's from meth use, which also releases catecholamines, or if they're even very septic or have been for multiple days, you actually unmask this negative inotrope mechanism, and they will get hypotensive, bradycardic, and basically be in a shock type picture. Another caution is in pregnancy. This is studied in pregnancy, but can actually cause uterine contraction. So you want to be very careful in a late stage pregnancy. If you are backed into a corner and need to use it, you can, but try to use some of your other agents. In drug use or pregnancy, this might be where you want to reach for another agent. Thank you for listening to this Pharmacy Minute. We'll hopefully be coming to you with more, and make sure you go like and subscribe this video.